Now for the lower limb, we're going to look at this a lot the same way that we did for the upper. We'll start off a lot with the osteology, and then we'll work our way down. Big picture setup, the limbs are very similar. If you think back to the rotation of the upper limb and how they rotate laterally versus the rotation of the lower limb and how they rotate medially. So whenever you get to your anatomical position, that's how you have your thumbs facing lateral versus the homologous structure, the big toe, being medial for the lower extremity, okay? So what you'll see is that you'll have flexor compartment, like flexor compartment for the arm is on the anterior side of the body, but the flexor compartment within the thigh is on the posterior, and it's all because of that rotation, and you can kind of use that and work that, sort of that roadmap as you go through the rest of the limb. Now, kind of a theme that you'll see here is that you'll see a very similar setup. A lot with the osteology, a lot with the muscle compartments, the blood supply, how they're formed, where they go. So some of this stuff might be a little bit familiar to you only because we've looked at the upper extremity already. So when you look at the head of the femur, you see, of course, the rounded head for the articulation with the acetabulum. You'll notice that the head is a little bit deeper than what we saw for the head of the humerus, because the head of the humerus, the way it articulates when the glenoid cavity is more for range of motion, whereas here within the hip, with the head of the femur and the acetabulum, that's more for stability. It's weight bearing, locomotion, walking around. So just the physical structure is a little bit different, but there is something that's a little bit unique to the head here versus the head of the humerus, and you'll see there's a small depression called the fovea. So specifically, we call that the fovea capitis. That is the pit in the head of the femur. So the fovea capitis, of course, serves a purpose. There's a ligament that stretches through the hip that gives some stability on the inside of the joint, and it attaches to that fovea capitis. Now you'll also see that you have the narrowing for the neck, and then you reach two structures called trochanters. Remember, a trochanter or a tubercle or tuberosity is just an outpouching of bone that allows for ligaments and tendons to attach. So in the upper extremity, we had the greater and lesser tubercles. In the lower extremity, we have greater and lesser trochanter. You don't see them as well from the anterior side, but if you look at posterior, they're very prominent. The greater, of course, is bigger than the lesser, but they serve similar purposes to the attachments for the rotator cuff muscles around the greater and lesser tubercle. You're also introduced on the posterior side to the gluteal tuberosity. That's where the gluteus maximus will have half of its insertion. Then you'll notice a posterior ridge called the linea aspera. It extends from the lower part of that gluteal tuberosity down towards the distal part of the femur. We'll talk about the purpose of that in just a little bit. And then from this posterior side, you see the two condyles. These are the knuckles. These are the articulating surfaces that will articulate with the tibial plateau that help to form the knee joint. So here you see the posterior part of the condyles, looks like two rounded portions, whereas if you look at it on the anterior side, it's much more flat, much more broad. It's still an articulating surface, but in this case it's considered patellar because of that patellar attachment and patellar articulation. You're also seeing the medial and lateral epicondyles, which are the outpouchings of bone that are just above the articulating surfaces. And then you'll notice one specific structure along the medial side, just above the medial epicondyle, and it's called the adductor tubercle. It's very specific because there's one muscle that will travel all the way from the medial compartment of the thigh down towards that knee, and it inserts at the adductor tubercle. The adductor tubercle looks like a little mountain sticking up, a little triangle, as it works its way up off of the medial epicondyle. Now when you look at the hip, you'll notice that the acetabulum, I can't remember, did we talk about the acetabulum before when we talked about just the overall osteology? A little bit. The acetabulum is the junction of the three pelvic bones, the ilium, the ischium, and the pubis. So if you're lucky and you look at the osteology, you might be able to see the three sutures that come together and they form like a big capital Y. And that would be all within the acetabulum. So of course, since 2/3 of this is the articular surface and the other third is a ligament, it tells you that that is, of course, the cavity for the head of the femur. And here you see the head of the femur as it fits into the acetabulum. There's that round ligament for the hip that we mentioned earlier, as it inserts in the fovea capitis. And there's also a branch of an artery that travels through, and that is a branch of the obturator artery. And we'll see the origin of the obturator. I think we saw that already with the pelvis, as it travels through the obturator foramen from the pelvis down into the thigh. But that is a branch of the obturator artery. Now it supplies just the very proximal portion of the head of the femur, not nearly the blood supply that it needs to supply the area. Okay, it's a very small blood supply that supplies the ligament itself, and then just the very proximal portion of the head right around that fovea capitis. There's other blood supply that we'll see in a little bit that really surrounds the region for that anastomosis. Now, big picture, when you look at the knee joint, I think some of you guys have had ACL and PCL issues before, right? Who was you? Tore your PCL, right? And that's the more difficult one to tear, just because of what it prevents and the actions that it takes to damage that. Most of the time you see ACL tears. Most of the time you see ACL tears in females during a non-contact injury. Okay, that's kind of like your most typical presentation for a torn ACL. But if you think about what the cruciate ligaments are, cruciate just means cross. Okay, so these are the two ligaments that cross within the knee joint that help to prevent the tibia from moving either anteriorly or posteriorly. So if you take your middle finger and you cross it over your index finger, okay, middle finger over index finger, and then just simply place that in front of your knees, that shows you the direction of these two ligaments. The ACL will cross from lateral to medial, and of course you see all of it from that view because it is anterior. And then the PCL crosses medial to lateral, but you only see half of it because it's hidden partially by the ACL. Okay, so these are the cruciates. See it right there? That's the cruciates, ACL, PCL. So what the anterior cruciate prevents is anterior displacement of the tibia. So what we're saying is that like if we're running straight ahead and we want to stop, the ACL is there to prevent the tibia and the leg from moving forward even though the body has stopped. So the PCL does the same thing. If we're running backwards and we stop, the PCL is preventing the tibia and the leg from moving posteriorly while the body is stopped. So that's why I say it's a little bit more difficult to tear the PCL, because usually ACL you can tear that while running, stop your trajectory, stop your running and try to move it to another direction. The leg wants to continue to move forward because those forces that are traveling up through the limb try to find a weak spot. The weak spot in this case are the ligaments in the knee. That's the first weak spot that it comes. So if the body's moving forward, you stop the pivot and run in another direction, the forces are still traveling upward through you and then trying to continue forward by way of inertia and possibly. And the same is true when it goes through. I can't remember how did you tear your knee tackle or
No, actually I was jumping to shoot across. I got pushed and I landed on the ankle that I landed on.
you landed on your knee?
Yeah.
Okay, so like,
That knee just landed right on.
which is a common presentation for that as far as the anterior damage to it. Because you see a lot of torn PCLs if you rear end somebody, automobile accident, the dashboard hits your knee and pushes your tibia, pushes your leg posteriorly. So that's the same thing as posterior displacement. Okay? And that makes sense, it's just that's not as common of a presentation for it. And then of course you have the medial and the lateral collaterals that help to surround the outside of the knee, either on the medial or the lateral side. Those guys just give the medial lateral support. The medial is very wide and very flat, and it fits right up against the knee joint. And it looks a lot different than the lateral, because the lateral looks a lot like the little golf pencils, or if you guys are doing putt-putt, and you have the little pencil where you keep score on your card. It's very short, very round. So they look completely different from each other. And the difference between those two, of course, besides being on the medial and the lateral side, is that on the medial is attached to what's called the medial meniscus. The menisci are just the buffers. They're kind of like the intervertebral disc of the knee. They are the buffers between the femoral condyles and the becomes torn altogether since they're attached. There's something called the terrible or the unhappy triad. If you guys have heard of this before, because real common presentation already says ACL tear. But oftentimes when you tear the ACL, you will also tear the medial meniscus because the amount of rotation takes place on the medial side of the medial to the lateral. So if you also tear the medial meniscus, by default, you usually will have some sort of impact from the medial collateral ligament because they're all connected. Okay? So that's the terrible triad, the ACL, the medial collateral ligament, and the medial meniscus.
Is the attachment point of the needle ligament to the meniscus just
It's not, it's a great diagram except for that. Thank you. That was my next comment. Is that it's not actually not representing the area like it should be. But this is completely flat. It's the meniscus here is attached. It's just not shown. But the lateral is completely separate. So that's why you don't have to tear the triad out here because it's harder to tear the lateral and tear that lateral meniscus because they are not connected. And there's less range of motion on the lateral side of the knee whenever you flex and extend. So the probability of injury is just smaller. Tibial plateau we mentioned just a little bit ago. That's these two cups or depressions on the proximal portion of the tibia. This is where the two knuckles, the two condyles for the femur rest down onto the knee, forming the actual knee joint. Now, if you'll notice, the head of the fibula doesn't extend up to the knee. So whenever you think of the knee joint, you're really just thinking distal femur and tibia. Now, it doesn't mean that the fibula is not a weight-bearing bone, because it is, but it's very, 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 very slight. Okay, it does bear some weight, but not very much. Football fans out there familiar with Donovan McNabb, former quarterback, Philadelphia Eagles, maybe. Donovan McNabb was a scrambling quarterback, right? So he ran around quite a bit in his younger days. He broke his leg during the game against the Cardinals, but he played the rest of the game. And the way that worked is that he broke his fibula, not his tibia. He broke his fibula. He was still able to play the rest of the game before he had to have surgery after the game. So it tells you that he wasn't able to run around as much. I mean, his mobility was limited, of course. He has a broken leg, but he was able to finish the game, and he broke it in the first quarter, late first quarter. So it tells you it's not a huge weight-bearing bone. It does provide some muscle support as far as an attachment to the original insertion, but it's not as much of a weight-bearing bone. He wasn't as mobile, but he was able to finish the game. So it just kind of gives you an example of how that is. There was also a player this year for the Super Bowl. I think it was somebody for the Falcons, maybe Mack. You guys help me out here if you've heard of it. I think it was Alex Mack. He was one of the big offensive linemen. Had a broken leg, broken fibula, and played in the Super Bowl as well. Yeah, it's not recommended. Yeah. Yeah. I didn't say it was. But I had McNabb starting on my fantasy team that week, so I was glad he did. And it was also the Super Bowl, so I mean, you take a couple of good shots, and 4 hours later, you deal with it then. That's not my professional opinion, because you know me, I'm nothing but professional. Don't laugh at that. Now, if you look here on the anterior side, you're introduced to something called the tibial tuberosity. The tibial tuberosity is a lot like the radial tuberosity in that it's got a muscle group that has an insertion. In this case, this is the anterior compartment of the thigh that is inserting here. So the quadriceps, the anterior compartment, has a common insertion at the tibial tuberosity. So if you were looking at an example of a second level question, we could put a pin in the tibial tuberosity and then just ask you which muscle group has insertion. You could just say quadriceps. Okay, that's an example of a second level question. But if you remember back to the radius or the radial tuberosity, we talked about the biceps, the way it has its insertion there, right? So it's pretty similar. Proximal portion for the fibula, you see the head as it travels downstream, forming the lateral side of the ankle, the lateral malleolus or the lateral mallet. So that's what we think of as the outside of our ankle bone. It's the lateral malleolus, the distal fibula. Whereas on the medial side, you see the medial malleolus. That's what we think of as the ankle bone on the inside of our ankle. Okay, so it's just the tib fib traveling downstream. You guys remember last week how the distal ulna was much smaller, whereas the distal radius was flared, much wider to give you the articulation for the wrist, right? Because it's not really the ulna that articulates with it. Here, it's a very similar setup. The tibia, very wide, very broad, much stronger. Distal fibula, not so much. Okay, very similar setup. And again, just like the tib fib, you have the interosseous membrane, or just like the radius of ulna, you got the interosseous membrane that connects the two bones, makes them stronger, connects the two together, but also provides an area for origin and insertion for a lot of the muscles that live on the anterior and the posterior side of the leg. Also having a proximal and a distal opening that allows for the blood supply, the nerves, lymphatics to pass back and forth from the anterior to the posterior compartment. So not to be a broken record, but very similar setup. You're going to see a common trend as we go through. Now notice the look of the medial and the lateral malleolus. You see it forms an arch, and that arch will travel downstream and straddle the talus, which is one of the tarsal bones of the foot. So let's talk about the bones of the foot, and then we'll come back to the ankle joint in just a second. So just like the hand, we had carpals, metacarpals, and then phalanges. It was the different divisions within the hand. Within the foot, we have tarsals, metatarsals, and phalanges. Now the carpals, remember, they were a little more organized. We had a proximal row of 4, and we had a distal row of 4. Here, we don't have quite the organization with the tarsals that we had for the carpals. But of course, you see the heel, that's the calcaneus. And we just talked about the talus a second ago, and you see the big articulating surface for the talus. Smooth on the superior part of it, smooth on the lateral, smooth on the medial. So you see how the distal tib fib can just sit right on top of the talus and have articulation all the way around the joint. Work our way down towards the toes a little bit more. Just in front of the talus, you're introduced to a bone called the navicular. It's called navicular because of the boat shape that it has, but also some of the actions that take place there, which we'll see in just a second. So talus, then navicular. And then some of your bigger bones that provide a little bit more stability sort of at the beginning or proximal third of the arch on the other side. You see what's called the cuneiforms. There's 3 of them. You could just call them 1, 2, and 3 if you want, with 1 being at the big toe. And then a larger cuboid out towards the little toe. All of those guys are starting to be a little bit more supportive bones at that point. And then the metatarsals are very similar to the metacarpals, the purpose of them giving shape and support to the middle portion of the foot, the arch. The difference here is that the base of the 5th metatarsal kind of sticks out in space. I always think of the coast of North Carolina, how it sticks out into the Atlantic compared to the other states for whatever reason. Help me to remember it. But the base of the 5th metatarsal does stick out in space. So a very common injury is to break that 5th metatarsal because it does stick out compared to the rest of the foot. And then once you get down into the phalanges, you'll see, of course, for the big toe, you have the 2 bones of the phalanx, whereas the 2nd through the 5th digit, you have 3. Very similar setup to the hand. The toe only has 1 joint in between the 2 portions of the phalanx, so that's the IP joint, interphalangeal joint. Whereas the 2nd through the 5th digit have 3 bones, which means they have 2 joints that are interphalangeal joints. So the row of joints that's closer to us is proximal, so that's the PIP joint, proximal interphalangeal joint. And the row that's distal to us is the distal interphalangeal joint, or the DIP. Very similar setup. The biggest difference for the foot compared to the hand when we look at the muscles will be the plane of reference. We said that the plane of reference for the hand was the middle finger, the 3rd digit, whereas for the foot, it's the 2nd. That's your plane of reference. Things will be adducted or abducted away from that 2nd digit instead of the 3rd. That's the biggest difference there. Now, when you look at the ankle joint and you look at the foot, there's 4 main actions that take place down here. And then all the other actions are sort of a combination of those actions. So first off, if you look at the ankle joint, we said that's the talus articulating with the tib fib. What happens here is that you have 2 types of flexion. There's no true extension for the ankle joint. And the way this works is, go back to your rotation. Lower limb undergoes a medial rotation. So when you look down at your foot, that's the back of your foot. Okay, that's the dorsum of the foot. So dorsiflexion is the first type of action that you see the ankle joint. Dorsiflexion, letting off the gas pedal, is dorsiflexion. You're taking the toes, decreasing the angle from the toes up towards your knee. Okay, that's dorsiflexion. Whereas the opposite action would be plantar flexion, stepping on the gas. Now you're taking the plantar surface of the foot, the bottom, which is analogous to the palmar aspect of the hand, and you're pushing it down into the floor. So that's the plantar flexion. So dorsiflexion and plantar flexion take place at the ankle joint. Whereas if you go one bone downstream, a little bit distal here, remember we said the navicular, the boat? This is called the talonavicular joint. And at the talonavicular joint, you have the other 2 main actions that take place. This is where you get some rotation, okay? The inversion is the first one. That's where you take the plantar surface of the foot and point it inward towards the midline of the body. Inversion. Inversion. Plantar surface pointing it inward. Whereas the opposite action is down here is called eversion. Taking the plantar surface and pointing it lateral. It's harder to do because the bony structure, the distal fibula, the lateral malleolus, goes further downstream than the medial. So it limits.
The one inside is inversion and the one outside is
Eversion. Like exhale, eversion. It's harder to have the eversion because of the lateral malleolus. It extends further downstream onto the foot than on the medial side. So it limits your lateral mobility. Inversion versus eversion. It also makes sense that when you sprain your ankle, 99 out of 100 times you sprain your ankle due to excessive inversion, right? Not excessive eversion, it's inversion, which puts an outward pressure on the outside of the ankle, but it's due to the excessive inversion action. Make sense? Every other action that takes place within the foot is some combination of those 4 main actions. Dorsiflexion, plantar flexion, inversion, and eversion. Okay. Now for the deep fascia for the thigh and the leg, you have what's called the fascia lata for the thigh. Sounds like a Starbucks drink, the fascia lata. Go to Starbucks and order it. Good luck, they'll laugh at you. And then if you look at the fascia, the deep fascia of the leg, it's called the crural or cruce, or leg once again, the cruce fascia, the crural fascia. But what it is, it's all one continuous layer of fascia that's sort of starting to wall off these compartments within the thigh or within the leg, okay? Now, if you'll notice on the thigh, on the lateral side of it, you have a thickening of the fascia lata, and this is called the IT band, the iliotibial band, or it's also called the iliotibial tract. You're saying the same thing, IT band. IT is easier to spell. Like we just said, that's a thickening of the fascia lata on the lateral side. It extends from the iliac crest on the lateral side down past the knee, down towards the head of the fibula. So that tells you it crosses the hip joint and it crosses the knee joint. So there's a muscle inside of here called the tensor of the fascia lata, which makes sense because it's inside of the IT band, which is simply a thickening of the fascia lata. Yes.
What did I do?
Iliotibial. there is a tensor of the fascia lata. The cursor's on it. It's kind of it's an elongated triangular looking muscle. So when it contracts, it pulls back up towards the hip. So since it inserts inside of the IT band, it pulls on the IT band. And since the IT band extends past the knee, when this contracts, it helps to abduct the entire lower limb. So you see people who jump hurdles, maybe some of you guys are track people, but you know, whenever you jump over a hurdle, you have one leg that's moving forward and the other limb is abducted to actually hurtle over the rest of the hurdle, right? It's that IT band, it's that tensor of the fascia lata that is a major player in you being able to do the hurdles with the abduction for the lower limb. Now quickly we will look at some of the nerves that are down here. First off, we'll look at the dermatomes. And I don't want you to get caught up in sort of the pattern or lack thereof of the dermatomes, because the same with the upper extremity, it's just not like it was in the chest, it's not like it was in the abdomen or the back, because there they were pretty horizontal, they made a little bit more sense. There is a rhyme or reason to this. But the take-home point that I want you guys to have today is that if you remember back to the upper extremity, we had pinprick tests that we could do on the thumb, index finger, and pinky that were testing C6, C7, and C8 respectively. And the point was is that if you have a pinprick test and the person tells you that they feel the pinprick all the way down at the distal aspect of the finger, that means all of the nerves that are working their way back are intact. Because otherwise, if you couldn't feel it here, obviously there is a deficit somewhere not allowing you to feel it downstream. The same is true here. We do it again here with the big toe, the second toe, and the little toe, but in this case it's L4, L5, and S1. Okay, L4, L5, and S1. Very similar setup with the pinprick test. If you have distal sensation, obviously the extension cords, the example that we use, are all plugged in so you can feel it downstream. If there is a deficit, that's when you need to know the true dermatome pattern to be able to work your way backwards to try to isolate exactly where that deficit is at. If it's only one dermatome, if it's two or more, etc. Okay? I don't want to go too far down that with the dermatomes. Now, you guys remember old Randy Travis, right? Randy Travis drinks cold beer, brachial plexus, everybody's best friend, right? You have a lumbosacral plexus for the lower extremity, but we don't go in depth nearly as much as we did with the brachial plexus. I mean, you have a lot of cutaneous branches that are down here. We saw some of these branches when we talked about the posterior part of the abdomen and the pelvis. But for our purposes today, we're looking at three main nerves. Okay, just three main nerves. The first one that we're looking at is here, the femoral. It's very large. Once it passes the inguinal ligament, it travels just underneath it. And if you want, you can go ahead and designate the femoral nerve as the nerve for the anterior compartment of the thigh. Okay, the quadriceps. Femoral nerve heads to the quadriceps. Does a little bit of sensory stuff downstream, but its main function, its main goal is anterior compartment of the thigh. Whereas here in the more midline of the body, you have the obturator nerve. Obturator nerve is traveling through the obturator foramen, traveling from the pelvis, heading a little bit more midline, like we said. It's going to travel to the medial compartment of the thigh, which is the adductors, the AD-ductors. It helps to bring the lower limb back to the midline of the body. Okay, so it's the main nerve responsible for that adduction group. And then the biggest one that you see posteriorly is the sciatic. Sciatic is a monster. Sciatic is bigger at its origin than the thoracic spinal cord. So kind of let that bounce around in your dome for a second, because sciatic is very big. Okay, it is a big nerve. Oftentimes people confuse it with a long, thin muscle just because of the size of it. Okay, it's a big nerve. And you'll notice there's a little bit of a trough in it, and that's because it actually will split into two separate nerves later that we'll see. So sometimes a common variation is that sciatic is already split all the way back up in the gluteal region where we first see it. That's a common variation, okay, it happens. But usually it's all together at that point. Sciatic is destined for the posterior compartment of the thigh, the hamstrings, and also does a lot with the leg and a lot with the foot. So whenever people, I know you guys have heard of sciatica before, like they tell guys not to drive long distances with their wallet in their back pocket because it's pushing against the sciatic nerve. And that's kind of a big deal because the sciatic nerve is responsible for that plantar and that dorsiflexion. So driving down the road, you need to be able to step on the gas. You also got to be able to let off, right? So you don't need numbness and tingling going on while you're trying to drive down the road. So sciatica is kind of a big deal, especially if you think about it from the driving aspect. And now you kind of see what that nerve is responsible for, big picture. And we'll talk a little bit more in detail, just a little bit. About to switch to the muscles. You guys good? Man, whose phone is this? It's shattered. What happened? Nobody's gonna claim it. I'll wait till it's over to see who picks it up. All right, first off, we start in the gluteal region. Now, you guys will see, for those that are hanging around for the med class in August, the gluteal dissection is probably the easiest dissection that we have for the whole course. Because you make one big cut, reflect the maximus, and everything else is deep to it. So it's the easiest dissection possible. So this is the midline. You can see a little bit of the sacrum here. This is the lateral side. You'll notice down here is the gluteal tuberosity. So we said half of the maximus has its insertion there. The other half of the maximus inserts along the IT band, or the iliotibial tract as well, okay? So when you think of the gluteus maximus, you think of hip extension. Hip extension. Another way of thinking about hip extension is simply standing up from a seated position. So whenever you guys work out, if you do squats, you're really working on the gluteal region as well as the lower extremity, right? Because that is what standing up from the seated position is. So squats really works out the gluteus maximus. You'll see the fibers run obliquely from its origin down towards both of the insertions, pulling on the maximus back towards its origin, helping to extend. But like we said, once you reflect that, all the other muscles fall in line. So if there's a gluteus maximus, of course there has to be a medius and a minimus by the rules of anatomy. So those guys are here, the gluteus medius and gluteus minimus. Originate on the outside of the ilium, and they share an insertion on that greater trochanter. Specifically on the very top part of it, the very superior part of the greater trochanter, and that's important to us because of the function of these muscles. These guys aren't really any kind of rotators for the hip. These guys are stabilizers, okay? The superior part of the greater trochanter. These guys are stabilizers for the hip. So every time you take a step, sort of your gait, your walking phase, the swing phase specifically, every time you take a step, these guys are triggered to make sure your pelvis doesn't get cattywampus. If you guys know what that is, it means out of line for those that aren't familiar. But this helps to stabilize the hip joint on the lateral side. And we'll talk a little bit more about that in just a second. And then the other 5 muscles that you see here are all responsible for lateral rotation of the hip. This whole group is responsible for lateral rotation of the hip. They insert on and around that greater trochanter. The piriformis is a big muscle in this region. Big for a couple different reasons, with some landmarks, some relationships that happen there. And then below the piriformis, you'll see you've got the superior gemini, or twin, as well as the inferior gemini, or twin. Sandwiched in between those two is the obturator internus. So what this does, this is our, for the gluteal region, this is our hot dog and hot dog bun relationship for the gluteal region. The two twins are the bun, and the obturator internus tendon would be the hot dog, because where we see this on the dissection is more here than it is back here. So in the dissection, we see much more of the obturator internus tendon, so it looks very white. Whereas the superior and the inferior are the muscle bellies, so of course you see the brown muscle fiber on either side, and then you have the obturator internus running right through the middle of it. Then just below that, you see the large quadratus femoris. All 5 of those running right on top of each other. Very similar actions with the lateral rotation for the hip. Now for the innervations back here, remember we said that sciatic is in the gluteal region, but it's not really doing anything here, okay? You've got a couple of gluteal branches extending from it, but you don't have the actual sciatic doing anything. Sciatic's just passing through. So normal orientation is that sciatic appears in the gluteal region from just below the piriformis. You see that here. And that it should run on top of the hot dog bun relationship and the quadratus femoris. It should. A normal variation, earlier we said that sciatic is split. So it's possible that sciatic is in 2 pieces back here. It's possible that one piece of the sciatic could split the piriformis, and then that throws people off sometimes. Rarely do you ever see it come over the top of piriformis. That usually just doesn't happen. But a normal variation is that it could be split, and it could be piercing the piriformis as it comes down. Okay, those are normal variations that you could see. But now when you look at the gluteal area innervation, the gluteus maximus innervation is the inferior gluteal nerve. Okay, the inferior gluteal nerve. Should see a fairly large branch of it. See it, it's showing you here as it travels across towards the iliotibial band. You see it stretching back here from the sciatic across. Now for the gluteus medius and minimus, the superior gluteal nerve innervates those guys. Okay, so inferior gluteal nerve is to the maximus, superior gluteal nerve is to the medius and the minimus. And then for the rest of these muscles, that group of 5 that we looked at just a second ago, from piriformis down, those are all just nerve to the muscle, whatever it is, nerve to the piriformis, nerve to the obturator internus, etc. Okay, smaller branches that come off, usually below the muscle, below the border of the muscle, so you don't really see these nerves from this view. Okay, so understand that they're there, but they're tougher to see. But pretty straightforward. Superior gluteal nerve for the medius and minimus, inferior gluteal nerve for the maximus, nerve to the whatever muscle for the whatever. Sorry?
They are all branches of sciatic?
They are. For the 2nd through the 5th, it's just nerve to the whatever muscle.
Sorry, finish what you were saying. The superior gluteal nerve.
Superior gluteal nerve innervates the gluteus medius and minimus. Inferior gluteal nerve innervates the gluteus maximus. And then for that group of 5, it's just nerve to the whatever. Nerve to the piriformis or nerve to the quadratus or the inferior twin or something like that. Now for the blood supply, it's very similar. If you guys remember back to the pelvis, we had the superior and the inferior gluteal nerve diving through the pelvis. And that was the relationship that we talked about where the superior gluteal artery dives deep between lumbosacral trunk and S1. You guys remember that? Inferior gluteal dives deep between S1 and S2, or S2, S3, that's kind of 50-50. Well, now you're seeing them after they've passed through the pelvis into the gluteal region. So the way this works is, again, piriformis is our border for these relationships. Superior gluteal artery is any artery that you see above the piriformis. Because there is an anastomosis between the superior and the inferior back here. So the way this works is any blood supply above piriformis is a superior gluteal artery. Any blood vessel that you see below the piriformis is an inferior gluteal artery. There are muscular branches that come off of that. Don't get focused on that. But this relationship, as far as being above piriformis or below piriformis, only works with the blood supply. It doesn't work with the nerve. Because obviously the gluteus maximus extends above the level of the piriformis. And we said that the inferior gluteal nerve is what innervates the maximus. So that relationship, as far as just location to piriformis, only works with these arteries: superior gluteal artery and an inferior gluteal artery. one thing to mention is that you will see a superior gluteal bundle sandwiched in between the gluteus medius and the gluteus minimus. So you'll see a vein, artery, and neurovascular bundle sandwiched in between the gluteus medius and minimus, and that is the superior gluteal bundle. So it's very likely we could tag the whole bundle and just say identify bundle, because if you know it's superior gluteal, then you should be in good shape, right? Because it's all the superior gluteal bundle. It doesn't work as well for the inferior gluteal, because that's a little bit more fanned out. But for the superior gluteal, it works well. Between the gluteus medius and the gluteus minimus. That's the superior gluteal bundle. Now, Trendelenburg sign. Have you guys heard of Trendelenburg sign before in reference to the gluteal region? What this is that it's talking about a nerve or two muscles specifically. It's talking about the superior gluteal nerve, and it's talking about the gluteus medius and gluteus minimus. Remember a little bit ago we said that the gluteus medius and minimus insert on the superior part of the greater trochanter, stabilizes the hip whenever you walk, right? And the superior gluteal nerve is the equation to those two muscles. So if you have damage to the nerve, or if you have damage to one of those two muscles or both of them, you will have a little exhibit that is called Trendelenburg sign. What this is that whenever you take a step, obviously one limb is on the ground, one limb is not, as you're taking a step forward, right? So as you're taking a step forward, the muscles in the hip that are off the ground aren't providing any support, because they're in the process of this walk swing phase, right? So on the opposite side, in this case, he's got his right foot off the ground, so use that example. Right foot's coming off the ground, left side needs to be stable in order to support the hip. So what happens here is that if you have damage to the left side, the left gluteus medius or minimus, or that superior gluteal nerve on the left, you no longer are able to stabilize the hip, and because of the bony structure of the hip, the weight now being forced to that side, since the right foot is off the ground, the hip will want to bow out. So the gluteus medius and minimus cross the hip, contract, and help to pull it back in line. Okay? So if you have damage to those two muscles or damage to that nerve, you will develop what is a Trendelenburg sign. The hip wants to bow laterally. Okay? So you'll see in this case, again, the right foot is off the ground. So the right foot comes off the ground, if you have damage here, the hip wants to bow laterally. So then if I'll take a step and there's damage on this side, the hip wants to bow laterally on this side. So you kind of do like a Trendelenburg dance. It helps you remember this stuff. I'll dance for everybody. Just you guys are special. This is my exercise for today. So this is the Trendelenburg dance. And that shows you a little bit of how the pelvis works or don't work. Yeah, steps. Nobody's recording that. Better not show up on YouTube. Does that make some sense? I was waiting for somebody to say no, do it again. There it is. Only for dollars this time. Yeah, it's okay to laugh. Now, as we move down into the hip, or to the thigh, we're going to talk about big pictures today. We talked about a lot of muscle groups last week and their collective actions. We're going to do the same thing today. There's just a couple of oddballs that are associated with the anterior compartment that we'll mention first, and then we'll get to the anterior compartment. The first one is here. This is called the iliopsoas, and it's only called iliopsoas after you cross the inguinal ligament. It's a combination of two muscles, the psoas major and the iliacus muscle. Once those two muscles cross the inguinal ligament, they merge together, forming the iliopsoas. And they are the only muscle that inserts on the lesser trochanter. Just the same as the subscapularis muscle of the rotator cuff was the only muscle that inserted on the lesser tubercle. Very similar setup. Okay, they are a major hip flexor. So if you guys have ever pulled a hip flexor before and it hurts so far into your back that you think maybe you've damaged your kidneys, it makes sense. Especially if you damage some of the psoas major, you see how far back that extends. Okay, so hip flexors can hurt deep within the pelvis and in the very low back. Oftentimes it throws people off with the pain. major hip flexor. Also, you're introduced to the sartorius. The femur is the longest bone in the body. This muscle originates before the beginning of the femur and inserts after the end of it, so this is the longest muscle you have, the sartorius. It originates from the as-is, the anterior superior iliac spine, so that tells you it is a lateral origin, and then it inserts medially on the tibia, just below the tibial plateau on the medial side. So it's also crossing both the hip and the knee joint, which means by the rules of anatomy, if it crosses a joint, it's got to have an action on the joint. So the sartorius is the major muscle that's responsible for crossing your leg. Okay, because it's crossing the hip joint, so it helps to flex the hip joint. By its lateral origin, it also helps to laterally rotate the hip. So it's flexing and laterally rotating the hip. And it's also flexing the leg at the knee joint. So this one muscle is responsible for crossing your leg. It's the major muscle for crossing your leg, sartorius. Considered an anterior compartment muscle. Both of these guys are innervated by the femoral nerve. Remember earlier we said femoral nerve, big picture, anterior compartment, right? Anterior compartment of the thigh. Now quadriceps, of course, is the major part for the anterior compartment of the thigh. We've already said these guys are innervated by femoral nerve. We've also said that these are extensive because they insert on and around the patella, but they continue all the way down to that tibial tuberosum, which means they cross the knee, having action, of course, on the leg, holding the leg anteriorly, extending the leg to the knee. Quadriceps, of course, is made up of 4 muscles. The rectus femoris is the most anterior of the 4, and it's also the most separated of the 4. Because if you'll notice, the other 3 muscles after that are called vastus, right? The rectus femoris sort of sits out in space more than the rest of it. So you can grab your hand around it, move it around, it's very moving. So there's rectus femoris, and then you have the vastus group. That's the little yeah.
Would that make it more easy to tear?
Not necessarily. I mean, if you're going to tear, because you're talking specifically about tearing just that muscle, or
I said for that muscle.
on that muscle, will you? Because I've been in my also, the reason I say that is that we see a lot of sprints. Not around the baseball tryouts.
I was nervous.
You're kicking the ball.
Yeah,
Kick the ball forward.
and then it's her top.
Remind me not to play any sports. Hey, I'll be honest with you, it's not that common. It's not that common to do, but I mean, I damaged mine. I didn't very much shit. It's not that hard. It's not that easy to do. Just without some sort of insult, like somebody else doing something. It's hard to do. But the vastus group, you'll see that these guys are directional terms. So there's a medialis, there's a lateralis. So it's the medial side of the thigh, it's the lateral side of the thigh. And then the intermedius is the one that is directly deep to the rectus femoris. So if you take the rectus and just move it to one side or the other, you'll see the vastus intermedius. Now, a lot like the obturator internus, from this view, you see more tendon of the vastus intermedius. Okay? So vastus medialis, lateralis, the intermedius. Intermedius looks a lot like the whitish tendon that you saw with the obturator. All of these collectively crossing the inserting of the tibial tuberosum for extension of the leg at the knee joint. Again, femoral nerve. Big picture. Now hamstrings. Posterior compartment. We already said sciatic nerve is responsible. There's a little bit more of a, as the sciatic starts to split as we get close to the knee, we start to see a little bit more specifics with the innervation. But for our purposes, let's just call it sciatic for now, especially in the hamstring region. Does anybody know why we call them hamstrings in the first place? What's that? Like ham? Well, it's in reference to a pig, absolutely. Yeah, the way that they, farmers and slaughterhouses They have to slice the throat and bleed the hog in order to process the meat. So they would slice the throat and then hang it up by its posterior compartment. They would put a hook through the posterior compartment of the leg and hang it upside down, or the posterior compartment of the thigh. So that way they would bleed out. Do you not eat pork? You don't? Well, I do. It's damn good. I love it. I'll tell you that right now. Yeah, it's all right. But that's how they get the nickname hamstring. So some things in anatomy make no sense, like acetabulum and vinegar cup and all this stuff. But yeah, hamstrings, there's actually some background to it. But the hamstrings share a common origin from the ischial tuberosity, which all of you guys are sitting on right now. That's the ischial tuberosity. They share a common origin, and then part of these travel laterally, part of these travel medially across the knee, which means these are, of course, your flexors of the leg at the knee joint. The one that travels the most lateral is the biceps. Okay, but in this case, we're in the lower extremity, so this is the biceps femoris. Now you'll notice, of course, biceps means two heads to it. There is a biceps long and a biceps short, right? The long head has an origin from the ischial tuberosity, but the short head is kind of the oddball. Okay, it doesn't originate from the ischial tuberosity. It originates more of the midshaft of the femur, close to that linea aspera, that ridge, that posterior ridge that we talked about just below the tibial tuberosity. So both the biceps femoris long and short head will collectively insert at the head of the fibula. Okay, so that does tell you that it's lateral side. Whereas the other two muscles of this region, the semimembranosus and the semitendinosus, will travel to the medial side. Semitendinosus, you see the name here, you see the muscle. It's named that because it's half muscle and half tendon. The diagram doesn't do it justice, right? So half of this is a belly of a muscle and half of this is a tendon, right? So it's pretty easy to see it. And then the most medial, I always say M&M, membranosus is the most medial. You'll see it here if you follow this line that doesn't exist. Right here, the semimembranosus travels all the way over here and then runs downstream, inserting along with the semitendinosus. So semimembranosus and semitendinosus, medial side of the knee. Biceps femoris, both long and short head, insert lateral side of the knee, giving you equal distribution of flexion across the knee joint. Pretty straightforward. Now for the adductors, there's a lot of words at the bottom, okay? You can read them if you'd like to. But the big picture is that these are adductors. These are bringing the lower limb back to the midline. And we've already said that these guys are innervated by that obturator nerve, the nerve that passes through the obturator foramen, sort of midline of the body. You'll notice that you have terms like adductor longus, adductor brevis, adductor magnus. And all of these just sound like names, but if you think about this, early on up towards the pubic bone, the longus, brevis, and magnus are stacked on top of each other from superficial to deep. Now, as you work your way downstream, they do fan out, inserting along the medial side of the femur, which makes sense because they are pulling the limb back to the midline. So this is the quickest point of insertion, so that makes sense. But early on up here, the longus, brevis, and magnus are all stacked on top of each other. And the obturator nerve, as it enters this compartment, will split around the adductor brevis, giving you an anterior portion on the anterior side of the adductor brevis and a posterior portion on the posterior side of the brevis. Okay, so there's a great relationship to look at proximal in the adductor compartment. Now the magnus tells you something. The name itself tells you magnus, right? So if you guys ever watch these strongman competitions, you ever see that stuff? I don't know if they show them as much anymore. But you see people that like throw boulders over their head, pick up cars on their shoulders, and pick up dinosaur bones and throw them. That last one's not legit, but I mean, you get the idea. And they're all named like Magnus something. They're all from Sweden. They all have blonde hair. It's just extremely built. They all look like me, basically. So when I think of Magnus, I always think of that, these big guys doing this stuff. But this is the biggest of these adductors. And I'm making a big deal about the Magnus because yes, the largest, the name tells you that, duh. But it also is the one that inserts on the adductor tubercle, that very specific piece of bone that we talked about that pops up in space just above the medial epicondyle. So it's possible to tag the adductor tubercle and then ask which muscle inserts there because it's only one. It's the adductor magnum. And you're also introduced to something called the adductor hiatus. You see this opening here, this little part of the magnum? The purpose of that adductor hiatus is to allow for the blood supply that travels through the anterior compartment to be able to go posterior and reach the knee and then continue down to the leg. So it's got to go through that adductor hiatus. So there's a lot going on with the adductor magnus, more so than just the name of it and being the largest of these adductors. And then the most medial of this compartment is called the gracilis. You'll see it here. The origin is just off to the side of the symphysis pubis and travels straight down towards the medial side of the knee, on the medial side of the tibia. Sometimes people get that confused with the sartorius because both are very long and both are very thin muscles. Just keep in mind that gracilis is an adductor. It originates and inserts from the medial compartment. So the gracilis goes straight down towards the medial side of the tibia, whereas the sartorius originates from the as-is. That's more lateral, right? And that's on the anterior compartment, and then it spirals around and inserts on the medial side. So just don't get those two confused. And I don't think I had a slide that talked about it, but if you guys have ever heard of the pes anserinus before, the pes anserine, this just means the goose's foot. There's a common insertion spot on the medial side of the knee where 3 different muscles have an insertion. Gracilis is one of those, sartorius is one of those, and semitendinosus is one of those. That's just for bonus points. Now when we look down towards the leg, we focus a little bit more with just big bulky action, the same as we did with the forearm. This is the anterior compartment of the leg. So these guys collectively, I mean, you can see the names, the tibialis anterior, extensor hallucis longus. Hallux is the fancy word for big toe, the same as pollex. Pollicis was a fancy word for thumb. So extensor hallucis longus, extensor digitorum longus. All of these are telling you sort of their destination, right? One's going to the big toe, one's going to the digits. So yeah, they have an action on those digits, but collectively as a group, when all of these contract, that's dorsiflexion. It's letting off the gas, okay? So you think about the innervation at this point, sciatic will split into 2 nerves called the tibial and the common peroneal, or the common fibular. P-E-R-O-N-E-A-L. Peroneal is in reference to the fibula. So when sciatic splits into a tibial or a common peroneal portion, the common peroneal will then split into 2 other branches, a superficial and a deep peroneal. So since we're looking at the anterior compartment, we're looking at the deep peroneal nerve, which is nothing more than a branch from the common peroneal, which is nothing more than one of the 2 major branches from sciatic. So we're not going too far down the line here, okay? I just don't want to get you guys lost. So that's why I said earlier, you have sciatica, you have damage to the sciatic nerve or some sort of impingement. This is how you can see how it affects now that dorsiflexion aspect, okay? Now the lateral compartment, there's only 2 muscles out here, and they are called the peroneus longus and peroneus brevis. You can also call them the fibularis longus and fibularis brevis. But these guys are responsible for eversion. Remember, taking the plantar surface of the foot and pointing it away from the midline. So these are your everters. So if the deep peroneal was the innervation to the anterior compartment, the superficial peroneal is the innervation to the lateral. Because if you think about what the common peroneal nerve is doing, it wraps around the head of the fibula, and then it splits into the superficial and this deep part, right? So these are the everters. They are on the fibula, so it makes sense that the common peroneal nerve would be responsible for their innervation. Specifically, the superficial peroneal branch of that common peroneal nerve. Everters, just these 2 muscles. Big picture. Now when we look at the posterior compartment of the leg, we think of the tibial nerve. Remember we said there's 2 main branches, 2 main divisions of the sciatic, tibial and common peroneal. Tibial is the main innervation for the posterior compartment. Now, the posterior compartment is actually divided into a superficial and a deep part. Okay? So the superficial part is what we're looking at first. And that's where you see muscles like the calf muscles, what we think of as the calf muscles, the gastrocnemius and the soleus. Okay, gastrocnemius and soleus, those are the two big muscles that form the superficial part of this posterior compartment. Gastrocnemius has two heads to it. People that work out a lot do a lot of calf raises. The gastroc usually shows up pretty prominently. You see the two-headed look to it. But in reality, the soleus becomes bulkier first. And the soleus is the deeper of these two muscles. So as it becomes larger, it pushes out against the gastrocnemius, which pushes the gastrocnemius out closer to the surface, which makes you see the outline of the two heads of the gastroc. But in reality, it's the soleus that bulks up more so than the gastroc and pushes out against it. So the soleus is doing the work, gastroc's taking the credit for it. It is what it is. They both work together though, inserting on the calcaneus, the heel, giving you plantar flexion, right? Stepping on the gas, plantar flexion, which is nothing more than doing your toe raises, your calf raises, okay? Same action. There is a very small, very tiny muscle, the plantaris, that lives in between those two muscles. And the muscle belly itself is about 1.5 to 2 inches long. And then the tendon travels all the way downstream and inserts on the calcaneus. So it's sort of running along with the Achilles tendon. It's running along with the gastroc and the soleus. It doesn't technically form the Achilles tendon because it kind of creeps out to the side of it before its insertion. So it's not part of that thick tendon, but it does live in between those two. And it like weekly, like 1% helps you with assisting with the plantar flexion. So if you don't have it, it's one of those deals that you don't wake up thinking I'm missing it. You just don't have it. It's a lot like that palmaris longus that we said, not everybody has that muscle either. So it's one of those that if you do happen to pop it, if the tendon does rupture, and it'll sort of coil up in between the gastroc and soleus, you can see how that could be problematic. It can be painful for a while. But oftentimes the doctors just tell you, just kind of suck it up, give it about a month, let the scar tissue form, instead of having the surgery to repair that tendon, because you don't really need it at all. Instead of going through a surgical procedure to repair it, and you're just introducing more injury, more potential risk for inflammation, etc. Just give it a month, let the scar tissue form, and you should be fine. Okay, but it's just one of those kind of random muscles that you see tucked in here. Now, if you look at the deeper group of muscles, again, this is still the tibial nerve. Tibial nerve innervates this group as well. You can see all the names that are on the board here. There's a tibialis posterior, there's a flexor digitorum longus, there's a flexor hallucis longus. They just sound like names right now, but the names are telling you, again, I'm going to the digits, I'm going to the big toe, or the one that's called tibialis is just having more of an impact on the actual ankle joint itself with the inversion aspect. But collectively, again, these muscles are going to be responsible for more of the plantar flexion. Big picture, right? As a group, this is plantar flexion. It's still innervated by the tibial nerve, like we said. They do have other specific actions once you get into the foot, but what we're looking at right now is those big bulkier actions. Now there is a relationship to look at, and the next slide is extremely grainy. It looks like it came over on the Titanic. It's the only thing that survived it, but it's a good diagram to give us the relationship that we look for with this posterior, the deep part of the posterior compartment. If you guys ever heard of that saying, just Tom, Dick, and Harry, you guys heard of that before? It's like you go out to the mall on Black Friday and every Tom, Dick, and Harry's out there. You guys heard of that before? Which means don't go to the mall on Black Friday. Just don't do it. I used to work at the mall on Black Friday. It's just terrible. Absolutely terrible. When I had hair back then, I would pull it out. Anyway, so some of you guys you've never heard of the Tom, Dick, and Harry reference. Well, you have now. And I like barbecue, so we're getting along well. But this works on the medial side of the ankle. Okay, and the reason we say Tom, Dick, and Harry is that this is the order of the tendons as they pass through the ankle joint. from the medial malleolus back towards the heel. So here's the medial malleolus, calcaneus is back here. So Tom, Dick, and Harry is simply the order of the tendons as they pass downstream. Tibialis posterior is the one closest to the medial malleolus. Flexor digitorum longus is next. And then flexor hallucis longus is the deepest of those three. So Tom, Dick, and Harry, tibialis posterior. Dick would be the digitorum part of the flexor digitorum longus. And then the hairy part would be the hallucis aspect, the flexor hallucis longus. Tom, Dick, and Harry, tibialis posterior, flexor digitorum longus, flexor hallucis longus. Tom, Dick, and Harry. Now you've been introduced to Tom, Dick, and Harry. I feel like I've done something today. I feel like this has been meaningful. That's why I woke up. I feel good now. It just helps you to understand the relationships back here, because when you look at these muscles, where they originate is different than where they cross the ankle. So for identification purposes, we always say look at the ankle, understand that Tom, Dick, and Harry relationship, and then work your way back. Because like I say, some of these muscle bellies will cross over each other, making it a little bit more confusing. So learn Tom, Dick, and Harry at the ankle, and then work your way back. Now on the foot, there's 4 different levels of muscle on the foot. And quite honestly, when we do the gross class for the medical students, we don't oftentimes dissect just a couple pieces of the third part and none of the fourth. Only because it's just tough to get to. You've got to break a lot of eggs to make an omelet in this case. You've got to tear through a lot of stuff to get to the deeper stuff. So what we do is we really focus on the hand because it's easier to get to. But understanding the setup of the hand helps you to understand the setup of the foot because it's very similar. Okay? So the first part, the first layer that we look at, you have an abductor for the big toe, so an abductor hallucis. You also have an abductor for the little toe, that's the abductor digiti minimi. So if you remember back when we talked about the hand, we had that thenar group that was a very specific group for the thumb. One of those muscles was an abductor, was an adductor for the thumb, right? You also have a similar setup with the adductor for the pinky. So you've got sort of a similar process here. The difference is that now you're exposed to the flexor digitorum brevis in the middle of those. Okay, so you're seeing the belly of the muscle of the flexor digitorum brevis in this first layer of muscles within the foot. The name tells you everything you need to know. It's going out to the 2nd through the 5th digit to flex the toes. It doesn't come from back up into the leg, right? So this isn't an extrinsic muscle. This guy originates and inserts in the foot, so it's an intrinsic muscle. So it doesn't have an impact on the ankle joint like flexor digitorum longus does. That's Dick from Tom, Dick, and Harry. So not only is it helping to plantar flex when it acts by itself, it's helping to flex these digits. Whereas here, this does nothing for the ankle. It's an intrinsic, and its sole purpose is flexion of the digits. Okay, that's kind of your separation from an extrinsic muscle to an intrinsic muscle. But all of this is happening on the first layer of muscles. The tibial nerve, once it travels through the Tom, Dick, and Harry relationship, goes down to the plantar surface of the foot, and then it splits into 2 branches, a medial and a lateral plantar. So when you look at all the muscles down here, big picture, you're thinking the innervation is a medial or a lateral plantar nerve, which is nothing more than the divisions of the tibial, which is nothing more than one of the 2 main splits of the sciatic. So we're not that far downstream, okay? Now the second level of muscle, this is where you see Dick from Tom, Dick, and Harry. You see the flexor digitorum longus here. You'll see that it travels in from the side, medial malleolus, right? So this muscle's traveling in at an angle, and then at this point, if we look at just its digital aspect, it's going to curl the 2nd through the 5th digit. Well, the fact that this comes in from the side tells you that if it pulls back towards the origin, it's going to pull the toes in that direction as well. So it kind of gives you an oblique curl to the toes. So most people's toes don't curl obliquely, most of them curl sort of normally like they do in the hand. So in order for that to happen, you have what's called the quadratus plantae. The quadratus plantae extends from the calcaneus, inserting on the flexor digitorum longus tendon. So when it contracts, when the flexor digitorum longus contracts and starts the oblique curl, quadratus plantae inserts on that tendon, pulling in the opposite direction to make what was oblique now uniform. Does that make sense? It's pulling in the opposite direction because the flexor digitorum longus is pulling medially. So this is pulling back towards the calcaneus to kind of make it more of a lateral pull at that point, which helps to make it a uniform pull. Does that make sense? I don't want to lose you here. I know we're getting close to the end. Quadratus plantae, uniform curl to the toes. If you didn't have it, everybody's toes would curl at an oblique at an angle. The last muscle to look at back here are the lumbricals. Just like in the hand, the bye-bye muscles in the hand were the lumbricals. If you wave bye-bye with your feet, with your toes, this would be the bye-bye muscles as well. Okay? Across the hip T joint, that parsotical joint, flexing that joint, but also extending the IP joints. Okay, it's doing the exact same thing that it did in the hand. But it's just doing it with the foot. It will be the bye-bye muscles of the foot. Now, to go deeper than this, you do have interosseous muscles, because you guys remember last week with the pad and dab aspect for the palmar and the dorsal interosseous. Some take away the dorsal abduct away from the midline, whereas the palmar ADD duct to the midline. You have the same thing here. You have interosseous muscles that are sandwiched in between the metatarsals, and they either pull away from that second toe, remember, because that's the plane of reference. So they either pull away from that or back to that second digit. So again, very similar setup, just slightly different. A little bit of blood supply here. Super big picture. Super big picture. Do you guys remember at what vertebral level the aorta bifurcates? L4. Yes, L4. So the aorta bifurcates at L4 into two big vessels, the common iliac. Common iliac splits into an external and an internal iliac. We already talked about internal iliac because that's destined for the pelvis. That's where the obturator artery comes from. FYI. Okay. External continues, crosses the inguinal ligament, and it simply changes names to the femoral. So at that point, you have the femoral artery in the anterior part of the thigh. That's the major blood supply from the anterior part. Quadriceps, those guys. It will run underneath the sartorius in a canal called the subsartorial canal, very clever. Goes through the adductor hiatus, that opening in the adductor magnus, and that allows it to reach the popliteal fossa. That's the fancy word for the knee joint. Then at that point, it changes names to popliteal. And we'll see the popliteal in just a second. But here you see the femoral, goes downstream, goes through the adductor hiatus to reach the posterior side. Now what you see here is a cut femoral. You guys see that's supposed to be the cut opening of the femoral? There is a branch that comes off, very proximal in the thigh, and it's called the profunda femoris, the deep femoral. Just the same as the brachial was the main artery for the arm, and it had a profunda brachii, a deep arm artery. This has a profunda femoris. This is the deep femoral artery, and it supplies the hamstrings. And what happens to it is that if you look over here, this is a posterior view. You'll notice that you see the term perforator a lot. This is one of those rare vessels that doesn't have a big anastomosis to it. Okay, the profunda femoris, once it goes posterior, it becomes these perforators. And what it does, we kind of call that an end artery because this is really like the end of the road for it. What it does is it perforates, it just splits up in these muscular branches. It just supplies the biceps, long and short legs, semimembranosus, tendinosus, and it doesn't really do much with the anastomosis downstream. So the vast majority of its use is done at that point, supplying the hamstring. one of the perforators, you should be fine, but if you damage the fundus femoris itself, then you got some serious issue. Because that is the main blood supply to the arm. Again, posterior view. You see here, all of a sudden this vessel just appears out of nowhere. It was the femoral on the anterior side. Now it's poked through the hiatus. We pick it up here in the popliteal fossa, and you can see here on the next slide what's going on. Anterior view now, switched it around. Anterior view goes through the hiatus. At that point becomes the popliteal. Now the knee joint, biggest joint you have, so the anastomosis that you have surrounding it is the largest anastomosis as well. So what's happening here is that you're introduced to something called geniculars. You see the term up there, genicular. Genu just means bend. So these are the arteries that are going around the knee. Okay. The key to a genicular is that they do not go to a muscle. They go to the bone. They go either to the femur, above the knee joint, or they go around the tibia, and a little bit of the tibia, if you're below the tibia. Now you've got muscular branches that come off of the genicular, but the geniculars themselves are direct branches from the popliteal that surround, that go to the bone and then surround the bone, providing an area for muscular branches to come off. Does that make sense? These are the geniculars, large anastomosis. Right around the knee. Now, the diagram you see up here is showing you the blood supply around the hip. Remember earlier we said that the ligamentum teres, that round ligament of the hip, has a little branch of the obturator artery passing through, and it supplies just the very proximal portion of the head of the femur. Well, the rest of the blood supply is coming from two major branches that come off of the profunda femoris. Okay, so before the profunda dives deep to hit the hamstrings, it gives off these two big branches. They're called the medial and the lateral femoral circumflex. Medial lateral femoral circumflex. Very similar setup to what we had in the arm with the anterior and posterior humeral circumflex. Okay, very similar setup. The medial, of course, travels medial, giving some blood supply up along the neck and then up towards the head. Here you see that ligamentum teres and the small obturator artery that passes through it, branch of it. But the lateral femoral circumflex is larger, so it has a little bit more branching that comes from it. You see it wraps around the greater trochanter and then supplies some of the blood supply back up towards the superior part of the neck and the superior part of the head of the femur as well. So it's really just surrounding the hip. Okay, major blood supply to the hip. So the image down here, it's grainy, but it's trying to show you that there is a break in the femoral neck. So a very common thing that you see in the older population, especially female, is osteoporosis. Osteoporosis, for lack of better terms, is dying bone. And if you don't have proper blood supply, the bone starts to dissolve. Okay, and this happens more in the female population. So a very common presentation for an older lady in the emergency room is broken hip. They'll say, I fell and I broke my hip. I was walking at the house and stood up and I fell and I broke my hip. Well, osteoporosis, specifically with fractures and breaks around the neck, what happens a lot of times is that you actually have to break when you stand up or when you walk, and then you fall down as a result of the break. But it happens so quickly that people think I fell and the jarring of the fall broke the hip, but in reality, the fact is, it's so weak, it's so dry, that it broke on its own, and then they fell because of the break. Like I say, it happens so quickly together, they think the fall caused the break. Now in this diagram specifically, she doesn't have a tibia or a fibula, so that could have contributed to it, but I'm not gonna split hairs. You know, I don't know why they didn't just go through with the drawing, and it's just laziness. Now, the popliteal, once it's done in the knee, will split into an anterior and a posterior tibial. Anterior and posterior tibial. Of course, the anterior runs on the anterior side of the interosseous membrane in the leg, posterior runs along the interosseous membrane, the posterior side of the limb, both traveling downstream. You have some branchings that come off from it, but the big picture setup is the anterior posterior tibial. Direct branches coming from the popliteal. And then the posterior tibial also crosses through that Tom, Dick, and Harry relationship, and then travels down to the foot. The same way that the tibial nerve traveled down to the foot and became medial and a lateral plantar nerve, posterior tibial artery travels through that Tom, Dick, and Harry relationship, splitting into a medial and a lateral plantar artery for the foot as well, supplying the bulk of the muscles there within the foot, especially on the plantar surface. Okay, big picture, very big picture. And then the last slide to look at is an area called the femoral triangle. Femoral triangle. The borders for the femoral triangle are the inguinal ligament, the sartorius, and the adductor longus. Inguinal ligament, sartorius, and adductor longus. Those are the borders for the femoral triangle. Inside of the femoral triangle, there are 4 structures. And from lateral to medial, we call this the naval relationship, N-A-V-L. I know that's not quite how you spell it, but it's for us to go. Naval, N-A-V-L. What that stands for is nerve, artery, vein, lymphatics, from lateral to medial. Nerve, artery, vein, lymphatic. Specifically, femoral nerve, femoral artery, femoral vein. And the lymphatics, not that they're not important, but the lymphatics, especially in that dissection, they don't show up unless it's some sort of pathology, so oftentimes we don't see them. Okay. So naval and AVL, femoral nerve, artery, vein, and then the lymphatics is the most important. And then deep to it, the floor of the triangle is formed by 2 muscles. One of them we talked about, one of them we didn't. On the lateral side, we have the iliopsoas, the hip flexor. That's the one, remember, that inserts on the lesser trochanter. So you have the iliopsoas is half of the floor. And the other half of the floor is a muscle called the pectineus. Or pectineus. I don't know. Pectineus or pectineus. It is an anterior compartment muscle. It's up there with, what's it? It's an adductor, excuse me. It's a medial compartment. But it's an oddball because it's innervated by the femoral nerve and the extension nerve. So it's sort of an oddball. But it forms the other half of the floor of the femoral triangle. So you need to remember your 3 borders. You need to remember the two muscles that form the floor. And you need to remember the naval relationship, the 4 structures that are inside of the triangle. Yes.
Can you repeat the 2 that form the floor?
Iliopsoas. Iliopsoas is the most lateral, and the pectineus is the most medial. Does it have it listed? No. What questions do you guys have?
I'm confused on the importance of Tom, Dick, and Harry. What's the point of it?
Tom, Dick, and Harry is just, it's not really that relevant, like from a clinical standpoint. The relevance is just from a learning standpoint. It's relevant from a learning standpoint. The tendons are in order. So for an identification purpose, it's easy to see the tendons of the Tom, of the Dick, and of the Harry, and then backtrack on those tendons to see the muscle. So there's not a true clinical relevance to it, but from a learning standpoint, it's kind of like a mnemonic. What are the questions you guys have? Keep in mind that next week is the flex week. So I plan on being here. I'll be here Tuesday, I'll be here